Hello and welcome to today's public talk from the NIHR Oxford Biomedical Research Centre. The Oxford Biomedical Research Centre is a collaboration between the University of Oxford and Oxford University Hospitals NHS Foundation Trust, which supports medical research. Today we're hearing from Professor Mona Bafadhel, who is Associate Professor of Respiratory Medicine at the Nuffield Department of Medicine and a Consultant Respiratory Physician. Mona's research primarily focuses on chronic obstructive pulmonary disease, or COPD for short, which is a group of lung conditions that cause breathing difficulties. I'll hand over to you now, Mona.
Thank you very much, Kelly. So thank you to the NIHR and Oxford Biomedical Research Centre. I'm going to talk to you about the STOIC study, so the Steroids in COVID study that has recently just been accepted for publication. So the global community, unfortunately, continues to experience the unprecedented nature and pandemic of the SARS-CoV-2 coronavirus, which has led to COVID-19 as the illness. As we know, it's a new respiratory virus and the first pandemic in over a century. Currently, as of the weekend, over 100 million people are affected, but this is likely to be an underestimate. We can also see that there's been over 2.5 million deaths worldwide, and this is also likely to be underestimated in some parts of the world where testing and recording can have difficulties. And unfortunately, some countries are also entering their third wave of the COVID-19 pandemic. At the time of the STOIC study hypothesis, over a year ago now, we had 1 million people affected globally, and there were 10,000 deaths reported worldwide. And the first wave was just starting in the United Kingdom. So where did we get to with regard to understanding or trying to ask the research question specifically for inhaled steroids in COVID-19 as a potential treatment? Well, from our experience, particularly in asthma and in COPD, what we could see early on in the pandemic, and reports particularly from the Wuhan community, was that respiratory disease seemed to be an infrequent finding in people hospitalised with COVID-19. And this is data that was pulled from China approximately around February, March time from the Wuhan hospitals that showed the proportion of these different comorbidities for patients hospitalised with COVID-19. As you can see, the Chinese population reported a lot of hypertension as a comorbidity, and there's also a lot of diabetes. And they found that COPD occurred in about 1.5% of those that were hospitalized for COVID-19. And from the report that was published last May here, there were no asthmatics that had been admitted to the COVID-19 hospitals in Wuhan. Compared this to the actual prevalence of these individual comorbidities within China, and this is publicly available information, but hypertension probably occurs just under 20% of the population in China. Diabetes occurs in about 11%. Our COPD is common and occurs in around 8.5% of people, and asthma in 1.5% of the population. So in comparison to those that were admitted to hospital with COVID-19, we can see that there was an underreporting, particularly of asthma and COPD. And this is unlike other endemic situations of viruses such as seasonal flu. Further on, published later on last year, pooled data for across the world, and this is from 11 studies pulled together of approximately 6,000 patients. We could see that it did appear that in people hospitalized with COVID-19, the risk was reduced in those who had asthma and COPD. So therefore, building on our original observations, that it seemed to be underreported. What else we saw early on in the pandemic was that laboratory findings had shown that it appeared that SARS-CoV-2 viral replication within the cells, so the epithelial cells, and these are the cells that line the respiratory tract, seemed to be reduced by inhaled corticosteroids. Here on the panel on the left-hand side, we could see different types of anti-inflammatory medication. including several inhalers, one being fluticasone, one being memetazone, one being cyclosinide. And we could see with 2 of them, there seemed to be an apparent reduction in viral replication of these cells. And finally, ongoing laboratory investigations, and this is just one example looking at COPD, showed that if we look at the sputum of patients with asthma or COPD, and in this population, the group from London looked at COPD patients, they can find that the ACE2 expression, so we know that this is an important receptor that allows entry of SARS-CoV-2 into the cell, appeared to be reduced in the presence of inhaled corticosteroids. Similarly, there's been similar laboratory investigations also showing similar things with asthma and inhaled corticosteroids specifically. What about using the knowledge we have as respiratory physicians from asthma and COPD? Well, we know that viruses are very common drivers for asthma attacks and COPD exacerbations. Now, these are acute events which are often associated with a worsening of symptoms that require further medication or indeed lead to a hospitalisation. We can also see that viruses have seasonal variation and they are worse during the winter months that lead to these exacerbations in asthmatic patients and in patients with COPD. Viruses are also, as well as being the common drivers for these exacerbations, they can be associated with a severe type illness that can lead to a hospitalisation for patients with these chronic lung conditions. As usual medication for patients with asthma and COPD, we prescribe inhaled corticosteroids because we want to reduce these exacerbation events, these acute deterioration processes that can lead to problems with people's symptoms. And we have seen for many years experiments that have shown reduced inflammation in the presence of viruses, commonly rhinoviruses, for example, in patients with asthma and COPD. Whilst we also know that if you look at a patient with an asthma attack, in data examining approximately 5,000 patients, we can see that if we give inhaled corticosteroids and the preventer medication, you can reduce the risk of getting a severe attack that leads to hospital. So we've had this information about asthma and COPD for some time with regard to viruses, and the original observation with regard to what was happening to patients with COPD and asthma from the Chinese COVID-19 studies led us to ask our research question, which was, when given early, can inhaled corticosteroids stop COVID-19 getting worse? So just to recap and tell you about the STOIC study design, our volunteers included anyone over the age of 18, and they had to have symptoms of COVID-19 within 7 days of study recruitment. Our symptoms suggestive of COVID-19 were all according to NHS guidance, which was new onset of cough and or new onset of fever and or new onset of loss of smell or taste. It was in a community setting in Oxford here and performed locally. We excluded anyone who were already taking an inhaled corticosteroid or people who are already on oral steroids, so tablets of steroids, or if they had a known allergy to the inhaler that we were using, and we use budesonide dry powder inhaler. So a volunteer with COVID-19 symptoms can contact the research team, and they were then randomized in a 1-to-1 ratio to enter either a usual care arm or whether they received budesonide inhaler to be taken at 2 puffs twice a day. We then asked our volunteers to complete symptom diaries, and we measured the common cold questionnaire and the flu pro questionnaire. We also asked them to record daily temperature and daily oxygen levels. And at 3 time points during the 28 days of the study, we collected nose swabs. And we also did bloods to measure antibody serology at the end of the study at day 28. At the time of the study starting, and certainly early on in the pandemic in the UK, there was a lack of community testing originally, so we didn't require a positive swab to be included into the study, but we did do swabs during the STOIC study, so we could measure SARS-CoV-2 infection ourselves. What we wanted to do was see if we could reach the primary endpoint, which was to try and see if inhaled budesonide could reduce COVID-19 related urgent care visits, attendance at emergency departments, or hospitalisation. And we also looked at secondary endpoints, which included clinical recovery, symptoms, temperature, oxygen levels, and also virus load within the nose. So this is a table presenting the study volunteers that took part. I've just put up here some characteristics of the population, and I've grouped them into those who are in the budesonide arm and grouped them into those in the usual care arm. So as you can see, on average, our population had an average age of about 45. There were more women in the study, approximately about 55, 56%. They were mainly Caucasians, and the comorbidities included a small proportion who had cardiovascular disease, a small proportion who had diabetes, and also a proportion who had either past history of asthma or current history of asthma not requiring inhaled corticosteroids. With this information, I would say that our group were certainly younger and not as poorly, with fewer comorbidities. On average, our volunteers had symptoms for 3 days before they were recruited into the study. Remember, we allowed people in as long as they had symptoms for 7 days. And we could detect SARS-CoV-2 from nasal swabs during the study in 94% of the population. So this is here highlighting the general symptoms at entry of the study for all of our volunteers. So really just to highlight that the commonest symptom that patients reported was cough in over 70% of the population, followed by new onset of fever in approximately 65% of the population, and about 40% of our volunteers also had a loss of smell and taste. Now, obviously, patients can have more than one symptom, and so that there is some overlap within these symptoms presented here. And this is just highlighting the symptoms at study entry between the budesonide arm and between the usual care arm, really showing that there was no difference in one symptom or another between the two groups. Perhaps there was a little bit more cough and fever in the budesonide arms, but this was not a difference when measured statistically. So straight to the primary endpoint, we could see that there were a significant reduction in either COVID-related urgent care visits, emergency department assessments, or hospitalisation in patients taking the budesonide compared to usual care. And this was estimated as a relative risk reduction of approximately 90%. The number needed to treat to prevent one of these episodes was 8 with a budesonide inhaler. There were 11 patients or volunteers in total that had the primary endpoint reached. And I've just here described what the different types of endpoints that occurred. So 3 volunteers had significant breathlessness and low oxygen levels. 2 volunteers had complications of their underlying comorbidities. 1 volunteer had a possible blood clot. One volunteer had a possible rib fracture, and 3 other volunteers were seen by their primary care practitioner on at least 2 occasions. And finally, 1 volunteer required ventilation with CPAP at the respiratory high dependency unit at the John Radcliffe Hospital. So what about the secondary endpoints? Well, the time to self-reported symptom recovery. Overall, for all of our volunteers, it took about 7 days for symptom to resolve. But what we could see was that symptom resolvement occurred quicker with budesonide, and significantly so, with a median difference of 1 day and an average difference of 3 days. Our volunteers in the budesonide arm took inhaled budesonide for an average of 7 days. We could also see that at 14 days, so halfway through the study, persistence of symptoms seemed to be more ongoing in the usual care arm, where 30% of the population in the usual care arm at day 14 still had ongoing symptoms compared to 10% of the population in the budesonide group. And when we looked at the questionnaires, remember we measured the chronic common cold questionnaire and the flu-pro questionnaire. Here I'm presenting the data for the common cold questionnaire. The common cold questionnaire asks for 4 domains of general symptoms, nasal symptoms, throat symptoms, and chest symptoms, and specifically asks for a rating score of whether there are severe, moderate, mild, or no symptoms of these, and these are then totaled up. And we can see that the volunteers in budesonide arm had a quicker symptom resolution with the common cold questionnaire. With the influenza, so the flu-pro questionnaire, this is a 32-point question, really looking at the symptoms of nose, throat, eyes, chest, abdominal symptoms or systemic symptoms. We could see that there was also an improvement with budesonide in terms of the flu-pro questionnaire compared to the usual care arm. I mentioned that our volunteers undertook daily temperature monitoring during the study, and we can see that also resolution of fever was quicker with budesonide compared to usual care. Here we are presenting some violin plots demonstrating that both the mean and median of temperature pooled over the 28-day period was higher in the usual care arm compared to budesonide. And here we're just plotting the daily temperatures for all the volunteers in the budesonide group in blue and all the volunteers in the usual care arm in red. And you can see that it appears that the temperatures are lower, quicker in the budesonide arm. When we looked at proportion of people who had fever reported, although not significant, there did appear to be a trend of fewer days of fever in the budesonide arm compared to usual care. We could also look at the first 14 days of the study, and again, although not significant, there appeared to be fewer days with fever and budesonide compared to usual care. And we looked at the number of days people needed to take either paracetamol, ibuprofen, or aspirin for fever. Specifically, we can see that there was a significant reduction in the number of days that antipyretics, so anti-temperature medicines was needed in the budesonide arm. There was no difference for oxygen levels between the groups when we looked at that. And as I mentioned, we measured viral loads within the nose at 3 time points, and we couldn't see that there was any difference in the amount of viral load between the 2 groups over the time period. So obviously, how do we put this data into context with regard to what we are experiencing and what we are learning from COVID-19? So the STOIC study is the first to investigate prospectively whether inhaled corticosteroids could work as a treatment for COVID-19. And this is a phase 2 study, and we are really excited that a further 9 studies examining inhaled corticosteroids are currently being tested throughout the world and are also awaited. So we will have more information with regard to validation in these trials. The study was an open label study design, so the usual care arm didn't have a placebo inhaler, for example, which would probably be the gold standard of randomized clinical trials. But as you can imagine, the urgent nature of COVID-19 meant that we were having to think about it on our feet. And of course, you can understand that the productions of placebo inhalers themselves take a significant amount of time and also add an extra amount of cost. As I mentioned, it's a phase 2A study, which therefore is not definitive. And we had to stop the study a little bit early because we were only able to recruit locally. However, the primary endpoint and our secondary endpoints are all suggestive that this favors inhaled corticosteroids as a treatment for COVID-19. And the other studies that I mentioned, the ones that we're waiting for worldwide, will either support or dismiss that. And finally, with inhaled corticosteroids, we recognize as respiratory physicians that they are relatively safe. We also know that they are widely available. And for budesonide itself, it is listed as an essential medicine by the World Health Organization that suggests that if indeed this is a treatment for COVID-19, it would be available for the whole of the world. So to conclude, we asked the research question: when given early, can inhaled corticosteroids stop COVID-19 getting worse? And I would summarize that inhaled budesonide given early in COVID-19 appears to reduce the risk of deterioration and improves recovery and fever. And this could be a treatment for COVID-19 illness. Finally, I have to give my special thanks to all the co-authors for the work, which has recently just been accepted for publication in the Lancet Respiratory Medicine. I want to thank the volunteers, the Oxford Clinical Trials Unit, and of course, the Oxford Hospitals NHS Foundation Trust, and the University of Oxford as the sponsor. But there has to be special thanks also to the STOIC team, and this is to the clinical fellow, Sanjay Ramakrishnan, who undertook many of the study visits, to Helen Jeffers, Beverly Langford, Christine Morusuku, and Karolina Karauska, who recruited as research nurses all the study participants, and to Mahdi, who processed all the samples in the laboratory. The study was funded by the Oxford NIHR BRC and AstraZeneca, who provided the budesonide inhalers. And as I mentioned, also the sponsor was the University of Oxford. Thank you very much for your attention, and I'm happy to take any questions.
Thank you very much, Mona. This is obviously a really exciting development, and you explained it really well, so thank you. You can leave questions for Mona in the live chat on the YouTube channel, so please do send us your questions. In the meantime, we'll get straight into them. So someone sent in a question in advance asking whether this treatment could be used to help people with long COVID. Could you answer that?
So it's an important question to ask, and obviously back in March 2020, we didn't really know much about the persistence of symptoms in COVID-19, and we didn't know about long COVID. The study design itself was not specifically to look at long COVID, and our study volunteers were in the study for 28 days only. But it's important to think about this, and it's important to think about how different treatments could be provided to patients either early in infection or later on in infection to try and prevent long COVID from occurring. We wouldn't be able to answer it from the STOIC study, but it's interesting to see that actually we could try and impact on reducing the persistence of symptoms in this group.
Great, thank you. Someone else has also asked, what role might the lack of blinding have played in the results of this study?
Yeah, I mean, it's an important question. And obviously, as I mentioned, one of the limitations is that it's an open label trial. I think what we don't know is we don't know in the nature of a new disease how much bias there is when one doesn't know whether there are actual treatments or benefits that could work. So it's an unknown about what degree of bias could actually occur in a new disease process. But in terms of how we did it, sometimes with the urgency of the studies and the nature of studies, as I mentioned, a placebo inhaler is often very difficult to to get and process, and it would delay the due time of when studies can start. We admitted as a limitation in the study, but our findings which suggest both the primary and the secondary endpoints are suggestive is reassuring, but also that there are validation or bigger studies that are also coming through. I must admit that of the 9 studies awaited that are looking in inhaled corticosteroids, only one of them is a placebo-controlled trial. So the other studies will also have the limit and weakness of not being a double-blind placebo-controlled trial.
Okay, thank you. Someone has asked, is there evidence that patients already using inhaled corticosteroids have experienced lower COVID infectivity?
So that's a really interesting question. And what the simple answer is that we're learning lots about it. The most important answer is that it would be a strong recommendation for patients already on inhaled corticosteroids to continue taking them as per normal treatment of their asthma or COPD conditions, for example. There's data coming out that it's looked at the proportion of people with asthma and COPD who get severe illness, and we're still learning lots about that. So my strongest recommendation would be that for those already on inhaled corticosteroids, for their underlying respiratory condition would be to certainly continue it.
Thank you. Someone has asked, could this research be used where high incidence of COPD in the population, where there's high incidence of COPD in the population to compare with non-COVID?
Yeah, so I think that's really having a population level question. So I know there's lots of databases that have tried to answer that question. And as more and more information and better recording of COVID-19 is coming out in the community particularly, we will have the chance to look at databases, for example, the CPRD database, that will be able to answer the questions of proportions of people on treatment with respiratory conditions who get COVID-19, adjusting for all the confounders that we know that could be occurred.
Okay. And have you found that this treatment is more effective in certain demographic groups based on, for instance, age or gender?
Yeah, so that's a really nice question, actually. So our population was anyone over the age of 18. And as I mentioned, our average age was 45. So they were a younger population than the group that we know probably have severer COVID-19 infection. In the Oxford community, our population were more likely to be Caucasian, so we can't really make comment on the risk of Black and ethnic minority risk with COVID-19. And finally, our population being younger, perhaps, also had fewer comorbidities. So we know that this is also, these are also risk factors for COVID-19. So the population is a younger, more general population. And looking at our events and our secondary outcomes, there was no real difference with regard to particular groups of people that were more at risk of getting ongoing symptoms or fevers or primary events. But obviously in a larger study, you'd be able to answer that question.
Great. And I think just one final question now. I mean, obviously you don't have a crystal ball, but with these other studies in the pipeline, do you have any idea of when, if the studies are also positive, that budesonide might be prescribed in future? Or, is that quite far down the line, do we think?
So what we know is that budesonide is currently being tested in the principal platform study. And so results are awaited for that. So we'll be interested to see that. The other studies are looking at budesonide in Spain. They've been recruiting since, I think, last summer. There's people looking at a combination of budesonide and formoterol in France. And then there's a couple of groups, both in, I think in Canada, and also across in East Asia, looking at a different inhaled corticosteroid. So there's lots of activity, and so it will be really exciting to see whether that helps answer the question. Of course, all studies have different study designs, have different study populations, and often may even have different study endpoints. But it will be interesting to see what the general themes of these are.
Great. Well, thank you so much, Mona, for taking the time today to explain all of this to us and to tell us about this really interesting study. We'll look forward to hearing more about it.
Thank you.
Thank you very much.